All right. So, probably at the beginning, we should just show everybody really quickly. If you didn't see the video already that got uploaded into SmileStream, in the collaboration page, it's in the library as well. But there's new functionality in SmileStream so that this little icon right here that is the Medit icon, this now just becomes a file sharing icon, basically. So if you want to attach a Medit Ortho Suite file, which you did, Sylvia. I'm not sure if you did it by two ways. Back in Medit Ortho Suite, you can always click the. It's not doesn't show up here, but on the previous pages here, let's click that button. You can always
Yes,
click
I
this
did.
little coaching. Is that how you did it?
Yeah, I did from here, the
Yeah, so you
coaching.
can do it from here, which if you create the coaching here, then it takes you to SmileStream and it attaches that file to it. One other way you can do it though is when you're in MeditLink. When you're in MeditLink, you have all of your attachments, and one of them will be your MOS file, and you can always click export here, or you can click export up here. If you do it here, you're just being very specific about what you want to export, but if you do it here, it brings up everything. So you look at the file list, and if somebody has STL files and images and all this stuff, it's the whole entire list, and all you need to do is unclick everything and just click the one that you want to send, which will always include, these kind of like subfolders. And then on the options, I usually say I uncheck this compress file because I don't really need it just to be a zip file if it's just a .medit ortho suite file, and then you export it onto your computer. So you can do it through this button or through these three little dots right here in this export button. But then you export it, download it onto your computer as a .medit ortho suite file. And then when you're in SmileStream, like if you already have a patient that exists there, then let's see, pulling the right one here. Then you can just go and click this and upload the file. And when you upload that file, like this isn't the right one, but here we'll do his actual file. When you upload the file, then that little dot turns blue and it shows that there's a file there. And then, so now it's blue. And literally, you can share with another doctor or mentor consultant. You can basically upload these files back and forth, and you'll end up with a running list of files here. So that's something that we didn't have before was the ability to attach these files to a case. But you did it the right way. So thank you for sending that to me. So then once I was in MeditLink, all I did is under our study club, I just created a case for this patient, and then I used the paperclip to attach the file you sent me, which I downloaded out of SmileStream using that same feature. And then we'll go ahead and open. We already had open. Let me close it so we can start from the beginning. So then I open Medit Ortho Suite. I know you guys know this, but just for whoever else might be watching now or later. Hi, Dr. Yang. Thanks for sending a couple cases. We'll get to yours next. Hi, Dr. Lorenz. So then when we open it, any files we have attached become projects we can work on, or we can hit cancel and start new if we have the STL files. So we're going to open the one you sent. And then we'll just go back to the beginning. So when the way you sent it, you'd already gone to the aligner output. So let's just look at what you sent me. You can see that if I go to look at the simulations, it warns me that if I do this, I'm going to lose any refinements that were made to the treatment. So this makes me realize that you already made refinements to it. So I'll cancel that and just open the aligners to see what you actually did. So this is what you sent me, which obviously this got submitted to progressive aligners. So this setup isn't going to be the one that's actually used. But, looking at the setup, I think this is great. So whatever you did along the way, it seems like you did a really good job. Let's look at what you sent me and then see what we get when we do it ourselves all over again. So you sent something that's got 20, how many? 17 stages in the upper. And it looks like it's shifting the midline. So I'm not sure if that's, we don't have the images for this patient as to whether we need to shift the midline, but we'll see when we work it up if that is the case when I work it up. You can see the upper midline shifting and just generally aligning the teeth in the lower arch. Yeah, just basically uprighting and aligning everything. Some IPR in the lower anterior. So let's see what our starting occlusion is. Looks like we've got a little bit of class 2 on the right side and a little bit of class 2 on the left side when we're looking at the canine, but the molars are pretty much class 1 on both sides. I can see contact between the distal marginal ridge of the upper molars and the mesial marginal ridge of the first molar. So class 1 molars, but class 2 canines on both sides, which makes me wonder if we have a Bolton discrepancy. Let's check that really quick. So I click right here, the Bolton discrepancy, and without considering the IPR, the lower arch is bigger by 1.65 millimeters. And so if we turn on the IPR, then we're down to where it's almost no Bolton discrepancy. So the IPR is justified there in the lower because once we align everything with that IPR, it looks like the overjet is pretty close to ideal, even though we have a little bit of class 2 still in the canine. So that tells us that some of this, like that's a pretty big bicuspid right there. And that may be why even with a class 1 molar, we've got a slightly class 2 canine. So I would say great job on this case, and we'll just need to see if we want the midline to shift or not. Because if we don't, then there's probably a way we can position our arch form to not shift the midline. And then I might, if I was going to use this for progressive aligners, which I know you're not, but if I was spending more time tweaking this, and you probably would have too, I probably would have messed with that molar rotation a little bit. Um, so we do want to rotate it out for the class 2 correction, but maybe not quite as much. So anyway, I think that's really good. Let's go back and start it over just to see what your process was, and we'll just do it together and see how quick we can get here. So to start over, if I come back and click on data editing, it warns me we're going to lose all of our work, but this takes us back and basically starts the case over. So we'll detach this so that we can reset everything. Okay, so just our standard, place these 4 points, distal buccal cusp tips of lower first molars and cusp tips of the 4s are first bicuspids, and that's our occlusal plane. That looks good to me, but let's check the upper incisor. So a fair amount of intrusion that's going to happen here on that upper incisor, but when I'm looking at this patient's upper incisors, you can see that the gingival margins are more incisal compared to the laterals. So we definitely want some intrusion of those uppers, plus they're a little retroclined and we have deep bite. So I think this is appropriate. We'll stick with that. See how it does on identifying teeth. I've been amazed as I continue to work with this, how much, if you get a good clean scan that's free of saliva, free of calculus and plaque, at how well it identifies teeth and segments. And then the cases where we really struggle with that are the cases where there's plaque, calculus, saliva. It's just not a real clean scan. And then we struggle. So super important to get a nice clean scan. And this one looks really good. So let's assume we're going to use this to make aligners on. I definitely would include the 7s as you have done. We'll just include that last little bit. I don't think it's going to let me click on it because it doesn't have a clean enough margin, but I'm just going to use the paintbrush and just paint that little bit in. So everything is numbered correctly and well segmented. I'm not going to say that this 7 is unerupted because if I do that, then it's going to try to put some tooth in the aligner staging, which I don't want back there because there isn't one. So if we're treating this with Medit aligners, we're going to be just watching for when this tooth has erupted enough that we want to rescan and get a new set of aligners that then includes that tooth. For right now, we don't want to include it. But I do want to include the others so that we get some aligner coverage of those teeth and we can prevent over eruption. Next, I think you did include a Ceph. So let's check that out. Nice. And that looks good. I don't know if you adjusted that already, but it looks good. I like the incisor position. A point looks good. B point looks good. I might move that up a little bit just to get that occlusal plane. It's always hard to tell which molar is going to be the one you can see in the model, but let's go with that right there. Nasion point, let's move that up a little bit to right there. Other than that, it looks really good. And then I'm always looking at the line between these two red points here, between gonion and nathion, so I can see if it seems to be paralleling the mandibular plane. And let's see how it did there. Pretty good job of placing that, but let's redo it just for fun. Put that right on the incisal edge. And then I like to go to the very distal of the upper terminal molar where it touches tissue, because I can usually kind of see the tissue in the radiograph. So that's something like that. But now let's ignore the tracing and look at yeah, see my model, I didn't place that well because look at how it's got that lower. So I'm going to reposition this lower. I think it's sized correctly, but I got it positioned too high based on that X-ray. So if I just come back here, same size, but I'm just going to reposition them. That looks better. But interesting, see now that upper incisor doesn't seem to match quite as much. So if I try to match the upper incisor, it would look something like that. And then the lower's off. So that's again, sometimes it's hard to trace and know which one are we tracing here. Let's go back and look. And let's move them up a little bit based upon what we're seeing on the next screen. And the only thing that changes is that's going to change your widths. So based upon the height, wherever you place this occlusal plane, it does affect the width value.
Just a comment, I've found that if you click on the central of the upper molar, in the center of the upper molar, that works pretty well
When
consistently
you're
because you position the upper molar
so in
right
this
on
step
the
right
X-ray.
here, are you talking about this step right here or the previous
Right.
one?
No, in this step where you're going incisor, molar,
Yeah, so
try
you go
doing
you're going
okay,
incisors and then you go kind of right in the
yeah,
middle of that molar. Like
yeah, but okay, fine. But I usually do it, where the line is.
I got you. So you put it where the upper and lower molars come together. Is that what you're saying?
Well, yeah, the upper molar, where the upper molar is the center of the upper molar on the occlusal, because that's a pretty,
Something
you
like right
may
here.
something,
Like,
yeah, like right there.
okay. So then when you come over here, then you put it right on the occlusal
Right,
plane. Gotcha.
right.
Oops, I mixed up my points here. Let's erase that point.
Uh,
So like
and I
this,
found
because
that to be a little better.
then it's consistently getting your widths measurement correct. Is that what you're saying?
Yeah.
Yep, gotcha. And it did. It came out really nice. That looks really good. So interesting that this patient is showing a width of 0.2, but an AMB angle of 5.7. So, when you have this is a skeletally protrusive case because this nasion point is so far back. And just looking at the patient, this does not look like a strong skeletal class 2. So I'm going to give more credence to this width value right here. A little bit of a skeletal closed patient with a MMPA of 22. If we look at the scale here, that puts us right about here. So just slightly skeletal closed based on how we traced it. And then upper and lower incisors are average to start based on how we traced it, but visually it looks like those upper centrals are retroclined. So let's go ahead onto here, and I'm going to reposition this arch wire. This will be the one thing that will shift the midline a little bit. So we saw the midline shifting. Let's assume the patient does not need to have the midline shift. Then I'm kind of ignoring where this midline is here, and I'm more looking at the overall shape of the alveolar process. And I'm keeping this, which they do line up here, the upper midline, lingual papilla here, and everything seems to line up pretty well. So I don't know if this patient needs a midline shift or not, but we'll just make it symmetrical on the molars after we align it with the top of the alveolar process. So it all looks pretty symmetrical on the upper. I have a little bit of dental asymmetry in this one. And then the lower, you can usually pretty clearly see that notch right there. And I line it up on that notch. So that gray line in the middle goes right on that notch. And then I align in the back, trying to find one that hits the gingival margin of the molars, which I think this is a good fit for this patient. It'll be a little bit constricted on the sixes, but I think a good fit for the patient. And then bite classification, it's giving it a class 1. And I would agree that that's, basically a class 1 molar, especially if we rotate that outward. So let's stick with the class 1 treatment plans. And then we get to this point. Now, this is a young patient, so I would agree that we would want to focus on idealizing everything rather than working on just an anterior alignment. But let's just look at the difference between the two really quick. So when we're aligning everything, if you look from here to here, you can see just by looking at it that you're going to have intrusion of the lower sevens and extrusion of the upper sevens, and that's going to level that curve of SPE. So if we look at the movements, you can see the intrusion of the lower sevens, which again, if we're going to do a whole aligner case on a young patient, we might as well shoot for ideal and see how close we can get. But if this was somebody who was, an adult patient who wanted limited treatment, or if we're getting closer to a revision to finish up the case, then you may want to stop trying to move those posterior teeth and just do a limited anterior only, which would leave that posterior occlusion and just focus on aligning the front teeth. So the difference between 1.1 and the limited treatment is if you watch those back teeth when I toggle between the two, you can see that most of the change, let me bring it over here, most of the change is happening back here in the back teeth between those two versions. And, we could try to idealize this a little bit better if we were doing limited treatment, but on a young patient, I think it's the right thing to do to go and start with an attempt to fix everything to ideal. So I like simulation 1.1 better. So I wouldn't mess with anything else here. I think that looks really good, but you can see that the upper and lower midlines are not lining up here. They did not line up at the beginning of the case. And so I don't think the upper midline shifted. Let's look at the superimposition. The way that we place it did shift a little bit. So it is shifting to the patient's left side. So I guess that would be a question of whether or not looking at the patient's actual photos. Do you remember, Sylvia, if this patient needed to have a midline shift at all, or was the midline pretty good?
That was the one thing that I asked, because in the picture that he sent me, it looked like a millimeter off to the left. But then he said, no, but I see her and she's fine. And so
Okay.
we didn't move the midline in the upper.
Okay. So then when you submit it to progressive aligner, you would say not to move the midline.
Midline, yeah.
Yeah. So in this case, if we wanted to not move that midline, we'd probably have to do some IPR to keep it from shifting. Because if we look at the posterior, if we look at the overjet in the back, it's pretty symmetrical one side versus the other. So it's not like, oh, well, I'll pull the arch wire. It's a little bit tight right here through the canines. So we could try that. Let's go to the upper. See how it's got more overjet right here at the canines and the bicuspid than this side does. But that's the direction that's already shifting the midline. So if I pull it over that way more, it's going to shift it even further that direction. You guys see what I'm saying? So when you look at the original, why would the midline be shifting? Well, obviously there's more crowding on the patient's upper right side compared to the upper left side. So it makes sense that when we align that crowding in, that things are going to shift to the left. So if that benefits the patient, great. If it doesn't benefit in the patient in this case, then you either have to distalize with the aligners in the upper right, or you're going to have to do IPR only in the upper right to try to keep it from shifting. So it'd be interesting to see in your progressive aligner setup, if they did not shift the upper midline, you should look at the setup and go, what did they do to not shift the upper midline? Was it distalization or was it IPR on that arch? And you can even see that there's some space on the upper left and there's crowding on the upper right. And so it makes sense that things are shifting to the left side. So let's move on and go from, we'll pick simulation 1.1. Let's see what that does for the patient's face. So if we felt like this was maybe a little bit too much advancement, we are getting a yellow light at 1.4 millimeters. Maybe we should consider doing just an expanded. So let's look at what an expanded arch form would look like. That'd be 1.3. Because when I looked at those arch forms, it felt like it was a little bit constricted. And then this is what we get if we go with expanded. Which I kind of like better actually, based upon the profile I'm seeing here. So I'd probably actually go with simulation 1.3. We get a green light on advancement. So let's go to the aligner output. And okay, so basically, well, similar to what you came up with. But if we were going to actually use this Medit aligners, that's when we'd go in and do some customization to final tooth positions. So like I showed before, guys, to do this, I'm clicking off of the model so that you can see the changes easily. And I feel like I like everything, except maybe that's just a little bit too much rotation to that molar and to this molar. And also you see the tissue, there's some tissue moving back there. I might go back and actually, before I start customizing all this, I might go back and see if I can clean up the way that because I must have identified some of the tissue as part of that tooth without noticing it. But I'll get a better fit of the aligner if I don't have the aligner thinking that that tissue right there is part of the tooth. But just a little quick correction to those molars. I would probably use the rotation tool. Let me see if I can line this up a little bit better so we can all see. I'm going to rotate that just a little bit like that. And then this one, just going to free position this one a little bit better like that. And in the lower arch, let's fix that rotation just a little bit. I want to move it buckle just a little bit further than that, something like that. And this to me looks good enough to say we can go ahead and start with this case. You know, we want to do a revision later. We can fix a few things later, but this feels like it's headed in the right direction enough to just order these aligners. Then I would look at the attachments. You know, this is pretty small clinical crowns. So as much as we can have attachments, it'll make the case go better, but I don't like the way that that one was auto placed. So we could either change it or we can just move the orientation of these, make them horizontal. Sorry, I'm trying to grab that little handle there. There we go. Get it positioned a little bit better. I probably don't need one on that 7 because that's just going to be erupting during the process. Same thing over here. Maybe reposition this attachment a little bit and get rid of that one. I'll probably get rid of that as well. Change the orientation here. Okay, and off you go. And then you can go and if you were going to order with Medit, then you could go and say, hey, I would probably order the first 10. So if I was checking out, I would go Medit aligners 1 through 10. And what's great about that is it gives me a chance to see one, is the patient being compliant? Two, how are we tracking during those first 10? And if we're good, I can keep ordering. And if not, I can rescan. I'll keep this new patient toggled on so that I get the little box and the little carrying case. And I'll say include attachments because I do want to have attachments on these teeth, which means I should be getting at least one template. So currently, they're going to revamp this a little bit right here so it's more clear. But currently, it shows that I'm going to be getting templates to put attachments on the teeth in the maxilla and the mandible. And it's a little bit confusing because you would think that it says here that we're getting 0 of those. You're actually getting, if you look up here and read the directions, it's saying that you're entering the stage number. So you're getting one maxilla and one mandible from stage 0. So that would be putting on attachments at, the start of the case. But they're going to make that a little bit more clear in the next version that comes out. But currently, if you want, at 3, you would say 3. That doesn't mean I'm getting 3 templates. That means I'm getting templates to start at stage 3 instead of stage 0. So that's how it's programmed currently. So great. Did you have any other questions about that one while we've got it up, Sylvia?
No, that's pretty much it. I did, as you said, the rotation of the upper sixes, and then added some at IPR, so I
Yeah.
can correct the class 2 on the left. I was worse on the right, and I did the IPR on the upper, so I didn't get that movement of the midline.
Yeah.
It's my
Perfect.
IPR. Mhm.
Perfect. Yeah. And I on a case like this, I'd probably start the case, and
Mhm.
that's the nice thing with Medit is you can just get the case started and then do a new scan. But if we were planning the whole thing out from beginning to end, yeah, I think you would want to kind of plan a little because it does look like we're going to have just with alignment, we might have insufficient anterior overjet. And we saw there was that Bolton discrepancy. So the lower is bigger. And so it does look like you'll need some IPR on the lower. So we could plan some IPR in here and get that overjet corrected better. But I feel like this is a case that probably would have treated successfully if we'd gone Medit aligners too, but you'll do great with the progressive aligners. So nice job on that. Let's look at the ones that Dr. Yang sent in for us. Is there a note here that I need to pay attention to? It doesn't look like it. All right. So let's close this one. And we want to look at 2 cases in the next 30 minutes if we can. So let's look first at this case, which again, all I have here is a Medit Ortho Suite file. Now, Dr. Yang, you did send me STL files, but I did not download those onto my computer because I think we're going to be sufficient in what you sent with this. So let's open that up and see what you've got in there. So I'm selecting the file that you sent already. Looks like you did already work up the full amount. So but it looks like you did not include a Ceph on this one, although it looks like you have one in SmileStream. Let me open up that patient. If I recall on this patient looked very skeletal closed. Yeah, so here is the patient. We have on the Ceph, I see it very skeletal closed, low angle. So we're gonna have strong muscles and dense bone and kind of a flared looking upper incisor. Lower looks a little proclined as well. And Nice, clean looking panoramic. Profiles a little bit full, but straight when you go from nose to chin. So I'd probably be looking to maintain that profile and try not to flatten out anymore. So let's have a look at the case without the Ceph. So let's go back over to the MOS case that you sent. And let's just look real quick at how you set it up. So we have here, I would note that it seems helpful when I do these cases to just quickly trim off all of this excess gum tissue, because sometimes it can throw things off. And I don't know if it did or not on your case. It doesn't look like it did, but just be aware if things are being strange, it sometimes has to do with extra stuff in the scan like you're seeing here. So I think this is good. Let's move forward with that. Let's look at your tooth identification. I'm going to do some renumbering here. I'm going to call, nope, you're right. I don't know why that looked wrong to me, but you're right. This 2-2 though, let's pick up the rest of that. That's kind of an interesting tooth that has like a lingual cingulum or talon on it that's been worn down by the patient's bite. Strong muscles, you can see all this wear. So kind of a deep bite, strong muscle patient. The rest of that looks good. In the lower, everything appears to be properly numbered and identified. Good. Your arch form, we went with the medium ovoid. Let's see if we can center this. Now, this was a case where you don't really have that notch that we see often. So now you're just going to have to look at the inside and outside alveolar process and try to center it at the top of that. And this arch form, just like in the last one, it's going to be basically maintaining at the 7s, but a little bit constricted at the 6s. So let's start with that one, because I don't see a lot of crowding in the lower. And then in the upper, I think you did a good job there. That looks good. So I would expect also to see a midline shift on this one, because see all the crowding on the upper left, and we don't have crowding on the upper right. So probably we're going to see a midline shift here. And let's see if this patient needs a midline shift at all, since we do have the pictures here. It doesn't really look like we want the midline to shift much. It looks pretty well centered. So we'll have to pay attention to that. Dr. Yang, what do you know if this patient's wanting to be treated with aligners or brackets, or what are your thoughts? What are you guys doing on this patient?
Um, Cost effective and most proficient way, so it
So
doesn't
we're
matter.
looking cost and efficiency. Okay. So she's open to either.
Yeah.
Okay. All right. So looking at this case, kind of an interesting occlusion here. It looks like this patient doesn't have a real well-established bite, because the wear that I see on the upper lingual would suggest that there'd be more bite there, but here it looks a little bit open. So either the scan doesn't have the bite correct so that it doesn't really have this articulated properly, or this is just one of those patients who doesn't really have a home base and roams all over the place with her bite. So assuming the bite is correct, we're definitely going to want to see class 2 simulations, because we've got, half a step class 2 on the patient's left side. But I'm just going to stick with the number that it's coming up with here. And then on the patient's right side, we've got all this excess overjet. Definitely class 2 on the patient's right side. Oh, here, I'll come over here. Because again, in the bicuspids, we're like half a step class 2. So let's adjust this a little bit. and get up again, somewhere in the two plus range for the value. We do want to look at class 2 simulations. Good thing they put that little progress bar. I always used to sit here and wonder if it was working or not when it just giving me the little circle. So before we start looking at individual tooth alignment, let's just look at what it's doing with that upper midline, how far it wants to shift it. Fairly significant shift of that midline towards the patient's right side. So we're probably going to want to do something. Probably going to want to do something to keep that from shifting so far to the patient's right, which would be we have to distalize in the upper left, or we have to do a bunch of upper left IPR, or we have to extract something in the upper left. And the most, conservative way would be to either try to distalize or to extract. I'm not to extract, to distalize or to do IPR. We don't have any eights, so, a kind of average sinus. But with these strong muscles, she's actually one that would distalize fairly easily. And, so that might be a consideration for doing aligners, is because we'd be able to do some distalization. Well, let's look at what else we've got here. A lot of intrusion needed in that lower, as you can see this curve of SPE. And that will improve with aligners, but it would be more effective with braces. So if we wanted to talk about most efficient and patient didn't really care, this would be a case where I would say start with brackets and even go lower 7 to 7 brackets to see if you can get this curve of SPE leveled. If the patient's not up for that and you want to try it all with aligners, we certainly have seen over and over that you're going to improve this curve of SPE with aligners only, but it's got pretty small clinical teeth, pretty short clinical crowns, and dense bone. So it's going to be a little bit slower going with an aligner start on this one. And let's just see what the planned movements look like. You guys see how it looks like it's constricting? It actually looks like it's constricting on the patient's right and expanding over here on the patient's lower left side. Let's go back and look at that. Looks like I positioned that pretty symmetrically. So I don't know why it's pushing it out more on one side versus the other. Let's kind of see if we can, instead of looking just at the 7s, I'm now kind of focusing on the bicuspids and these 6s. And I'm going a little bit more off of keeping it symmetrical with those teeth rather than just looking at the base of the 7s. So I'm looking at the bicuspids, the distance between the arch form and the gingival. And let's see if we like better the way it aligns if I do it like that. Which then when you look at the lower arch, you can see that probably if I just look at the individual arch, it will look more like a symmetrical alignment. Still kind of seems to be constricting on one side or the other. So it's constricting on the lower right 6, but expanding on the lower left 7. So some asymmetry in that arch. And then also with that adjustment that I made, look what it did to the overjet. Now we have big overjet on the upper right side and insufficient on the upper left side. Let's see if it's symmetrically expanded. When you look here, it looks pretty symmetrical as far as you don't see a lot of expansion on one side versus the other, but you do see kind of a difference between the extrusion and the intrusion. And you can see that when you look back over here at how much there's a vertical difference left versus right. And I think this would be another reason to want to start with brackets, because if you put brackets upper and lower 7 to 7, you're going to be able to level out all of these irregularities that it's hard to do with an aligner when you have one side versus the other side that they need to intrude and extrude differently. So if you were to say like what's going to be the most efficient for this case, I think braces are going to be the most efficient for the case. The only reason why I like aligners is one, she doesn't really have that much crowding rotations. And so it does seem like a case that she could go to aligners at some point in. When you do go to aligners with those strong muscles, you'll definitely want to use lingual bite ramps so that she doesn't bite on the aligner in the back and intrude those back teeth. And probably want to do it, after you've leveled and aligned with braces for 4 or 5, 6 months, so that then you could start doing some distalization. So you'd be doing some distalization in the upper and some mesialization in the lower, plus a little bit of expansion. Let's look at an expanded wire. You see we're getting a yellow light and a 1.454 millimeters of advancement. And so if we go to an expanded without IPR, we'll just do this expanded arch form class 2 elastic. Oh, I was like, why'd that all of a sudden jump up to 2.59? But that's because in simulation 1.1, I wasn't adding the class 2 correction. We were just looking at the advancement for the alignment of that curve of speed. So we do need to consider the class 2 correction because we haven't even talked about that yet. So the minute we go simulation 2.3, which is expansion, you can see that's way too much advancement in the lower if we're using just lower advancement to correct the class 2. So this is a case where I really do think probably, I don't want to extract in this patient because how strong skeletal close the patient is. So I think that leveling and aligning, starting this case with brackets and then transitioning over to aligners after everything is leveled and aligned, so maybe I'd start aligning maybe on 016 NiTi because you really don't have any bad rotations that need to be corrected. So I'd try to get upper and lower 7 to 7 bracketed. I'd probably put some lingual bite ramps. You'd have to get the big ones though, so maybe not because she has a lot of overjet there. So I don't even know if they would work in composite on the teeth unless you use the bigger ones. But get the case leveled and aligned, 7 to 7 brackets. Start with 016 NiTi, switch over to 18 by 25, keep that in there for a couple months, and just get the challenging movements that you're going to have a hard time with aligners, this leveling, the curve of SPI, and correcting this kind of canted plane right through here. Get that all leveled out. Then you could switch over, get a new scan, and switch over to aligners, and then we're going to be doing some upper distalization with just a little bit of lower advancement for the class 2 correction because she can't handle all of the class 2 correction by advancing the lowers. It's too much for this patient. So you do need to combine some upper distalization, and that would avoid having to extract this case. When you do go, we can look at it again when you get to that point, but when you do get to that point, let's have a look at the aligners. Okay, let's actually pick the distalization plan here. And let's go look at that in the aligners because I want to show you the lingual bite ramp feature, which you guys might not have seen. Why don't we fix these teeth too really quick? So take that tooth. And one of the easy ways to fix that is you see the angulation change here says 22 degrees. Rather than come and fidget with this, I can just take that and put it back down to 0. I can manually enter 0, which puts that tooth back where it belongs. It does need a little bit of angulation change though. So let's go ahead and increase it until visually it looks like it's angled properly. Something like right about there. Something like that. And then we can change the vertical. This is intruding. You can see it's intruding. So let's select that number and give it a 0 so it doesn't intrude. Well, it does need some intrusion, doesn't it? So let's go ahead and increase that value till it looks like it's the same as the other tooth, like that. And then I'm going to close these spaces and IPR by switching over to IPR and just clicking on both of those to delete them. And we'll go back over to tooth movements. So you're not going to accomplish this, what we're seeing right there in aligners. You would do that in brackets first. But as far as the distalization goes, we would be, and again, we'd probably want to change the angulation of these laterals. Let's do that really quick. So back on tooth movements, let's go to those laterals and click back on angulation. And let's just manually make that look good. We'll do it on both sides and then we'll get rid of that IPR. So you can see that these teeth are tapered. So when you go to bracket them, bracket based on that mesial line angle so that you can get some of this distal root tipping while you're in the bracket. Because these teeth are going to need it in order to look good. So let's get rid of these spaces. And then back to the tooth movements. Now, this is showing us that we may have some kind of a functional shift here. Again, I'm not 100% trusting. I think you should, well, let's look at the pictures and see what we think of the bite here compared to what we've seen in the pictures, because I'm not 100% trusting this bite registration on this model here. So I'm not sure that that's 100% accurate what we're seeing. Sorry, let me undo what I just did there. But we don't need to distalize quite as much as it's showing. And we do have, interesting here, we have a bolt discrepancy in the lower anterior, but if we go 6 to 6, it's in the upper. So that's kind of interesting. Let's look at the patient's pictures really quick and see what we think about the bite. Yeah, it's hard to tell.
Yeah.
But if I,
Clinical, I remember is 4 millimeter. If you look at the first page,
when you say first page, you're talking about in SmileStream or back over in Medit?
the smile stream, the tooth, like here, you can see I record the class relation, like 3 millimeter or 4 millimeter.
This one right here?
No,
Oh,
the
when you're
first,
looking at,
yeah,
oh,
yeah,
because
yeah.
your classification tab is what you actually saw clinically. The only thing I'm looking
Yeah.
at here, yeah, so when I look though at the way that the posterior teeth in the photos come together and with her
Mm.
strong bite, let's look at it again here really quick. Which won't really matter if you decide to start brackets first, because if you start brackets first, you'll be getting a new scan anyway when you take everything apart.
Yeah.
But it does look like it's a little bit open right through here. It's not really tight right there, but when we look down at this view, it looks like you have decent contacts in a couple different spots. Let's try to duplicate this view right here in the model. Let's go back to where we can see the start condition and see if, so let's turn off the attachments for a minute. And let's go back to the start and kind of see if we were to angle it the same way where how are we looking? We're looking kind of from an inferior view, kind of looking straight. If I walk straight, I would hit the lateral incisor. So if I go back over here and I go, whoops, and I'm coming from a inferior view, a little bit like that, and I'm coming straight at that lateral. It almost seems like we're kind of from that type of an angle in the photo. The photo is from like here back. That's what makes me wonder if we have the same bite. But again, if you're going to start with brackets, it wouldn't matter. But if you're going to start this case with aligners, I'd really double check. Let's see what this is showing the occlusal. Because we can turn on
Okay.
the occlusion right here. Let's
Yeah,
see.
looks a little off. I remember it was tight.
So see, when I turn on the occlusion right here, it's showing that currently the only place where there's any occlusion is really heavy on her posterior right side. It doesn't show any occlusal contacts anywhere until you get to basically those 3 posterior teeth on the right side. in the upper.
Mm.
All of this blue means there's no contacts. It's not till you get the
Yeah.
green. There's a faint contact, and there's the first solid contact, and then very heavy through here. So with how strong her muscles are, I kind of question that this is actually her bite, but she may be one of those that's just kind of like wasn't biting down, or maybe she was anesthetized when you guys scanned. I don't know, but I'm not sure I 100% trust this starting bite right here. So that would be my
Yeah,
thought
me
on
too.
this case is probably start brackets if you and the patient are willing to. Stay like 6 months in brackets and see if you can get this case, which is kind of goofy, get it all leveled and aligned as much as possible with brackets, and then switch over to aligners for the purpose of doing upper distalization so that you're not correcting all the class 2 with advancing the lower. And I wanted to show you guys really quick this feature. So if I wanted to make Medit aligners and actually put the bite ramps on, I go down here. Let me show you how I got here. I click down here on this treatment refinement tool that we keep using. But instead of a tooth movement control, let's fix this molar really quick. Instead of the tooth movement control, we are going to change over to the attachments and click on the incisor. And right here is a bite ramp. So we now have bite ramps and little torque and rotation ridges. So we're going to put a bite ramp on this tooth by just clicking on it. And we're going to put a bite ramp on this tooth by clicking on it. And then as far as positioning it goes, there are also large ones, and she's got a large overjet, so we probably want large when we get to the point where we're going to go to aligners. And I want to make sure that when she bites, she's going to be hitting those, so I can slide them more incisally if I want, and change the angulation. See, that to me looks a little bit more likely that if she were to bite down, she'd be hitting on those bite ramps somewhere along the way. Because this is this, let's see if I can go back to the start of the case. See if it'll put it into the setup for me now. So whether you use progressive aligners or Medit aligners, when you do switch over to aligners to do the distalization, you'll definitely want to use bite ramps. And you'll definitely want to use class 2 elastics. So you'd also do the button cutouts. So let's just see. Oh, they currently haven't got the programming so that you can see. Oh, I turned off the attachments. There we go. That's why. So when you go back to the very start of the case, based upon how I place those bite ramps, it does look like the patient would be biting on it right there. And then as the case progresses, you get more and more biting on those. But so you can see the long treatment because of distalization. And I think it might be distalizing a little bit more than what we need to, because our overjet is, I don't think you'll need quite that much distalization. So if we want less distalization, we can either adjust the final position of the back teeth, or we can go back and change how much bite classification we put in. But if I wanted less, let's show you that really quick. Less distalization. Okay, so I have to go back to movements again, and I look at the start and the final, and I look at the overjet, and I go, I don't want to distalize that much. I'm ignoring the fact that right now it looks like our laterally we're off on one side versus the other. I think that's going to be fixed when you go and do your leveling and aligning. But let's just look at how far the molars are distalizing. So here's the start. And if I want to reduce that so that I don't have insufficient overjet without going all the way back to the start, then what I'm going to do is I'm going to go to the tooth movement. And I'm going to click on this tooth and say currently it has got 1.7 of mesial and distal translation. So I can say I only want 1. Let's just say we only want 1 instead of 1.7. When I click back over, that's going to move that tooth up, right? So now it's like, oh, well, if we move the tooth up, now there's a collision between these two teeth. And I'm okay with that. Let's fix the rotation a little bit here. Let's move it a little bit to the lingual. That was the wrong one. That was tipping it. I want to move it translating. Oh, that's the right one. So that should be translating. Then let's move it a little bit more distal here. So something like that. Okay, then we do the same thing on the other side. We either manually move it. So I'm just going to manually move it up so it looks like the other one, somewhere around 0.8, 0.9, like that. So now I can see how much distalization it's got on there. If I want, I can manually do it, say 1.3 or something like that. So currently I've got 1.2 on the patient's upper right, and I've got 1.3 of distalization on the upper left. Let's fix the rotation a little bit. So now I have these red numbers here. So what I do is come up to the IPR, and I'm going to delete both of those, and it will move everything forward. So this is how I adjust how much distalization I'm going to get in the setup. So now if I go back and look at the overjet in the front and go, okay, that's how much overjet I want. Again, I'm ignoring the left and right because I could go back and fix that with the way I position the arch form, but I'm just looking at how much it's distalizing. And if like, yeah, that's how much I want to distalize, then when it recalculates, because I move the last molar position, you'll probably see that the number of aligners stage is going to come down because it's not moving it as far distal. So now when we go back and look at the setup, you can see that the amount of distalization has decreased because I moved the final position of those molars. Okay. We're right up against the hour. I will have a look when I get a chance, Dr. Yang, at that other case you sent, which is really interesting, and just maybe give you some thoughts through email. And then if it's not a rush on that case, we could always look at it next time we meet. But next time is Christmas Day, so we're not going to be meeting in 2 weeks. We'll be meeting a month from now. So you and I can have a little private conversation about the other case afterwards. But any thoughts, questions, comments on some of the things you've been seeing today in what we're doing?
Pretty insightful. Thank you so much, Dr. Harold.
Yeah. And, I hope that, so it's just to let you all know where we're at. We will eventually, probably by like April or May of next year, have designers who have even more tools inside of the software to customize things even a little bit more so that you could either work with a designer if you're going to order Medit aligners, or those additional tools will be available to you. Little things like, hey, I want to change the arch form a little bit. I want to shift this a little bit to this way and a little bit that way, where you'll be able to make those adjustments. And then you'll be able to just order Medit aligners, because you can work with a designer. Because I feel like to order Medit aligners right now, you have to feel pretty comfortable about the fact that you like what you've done here and that you feel like it's doable. But for me, I would look at this case and go, well, I know how I want to treat it now. I got to go start with my brackets, and then I'm going to come back and scan and reevaluate. And then I have the choice of ordering some aligners here or going with progressive aligners for a case like this.
Mm. So I have to warn the patient that she's going to get uglier, right? Because the teeth will be more protruded
Yeah,
during
and if we go,
treatment.
let me save this first. So I'm going to save this as my aligner workup, so I don't lose what we did here. And then I'm going to come back. See, it says you're going to lose what you did, but it's okay. I already saved it. I'm going to come back so that you can look at what's going to happen in simulation 1.1. And of course, I don't want to show the patient this. So let's change that really quick so it looks good here. So you see I hit the little tooth orientation tool, and I'm going to click on angulation. And let's change the angulation of this tooth. You see why it's off? We want to make that look like it matches that incisal edge, kind of matching that mesial line angle. And that I'll probably have to do the same thing to the other incisor. Oh, it didn't help much, did it? Let's try again. That looks pretty good to me on that incisor. Let's fix this incisor. That should make it look a lot better. Let's see. So something about the way that it's straightening these teeth, it's shifting it over, which is, I'm on simulation 2.6. Let's go back and look at 1.1. It should look better on simulation 1.1. There you go. Because it's not distalizing the teeth. So I would look at this and go to your patient like, we're going to level and align your teeth. And this is basically what it's going to look like unless your bite is different than what's recorded here, which I think it is a little bit. But basically, this is what you're going to look like by the time we're done leveling and aligning. It'll look a lot better. The teeth will look a lot more leveled in the front. But as far as the protrusion goes, we're not really changing by leveling. We're not really changing the amount of protrusion in the upper. Maybe a tiny little bit. And in the lower, we're getting some advancement from leveling the curve of Spee. And if you go back and look at her Ceph, most of her profile is being maintained by her upper incisors. So I think by the time you level, her profile really won't look worse or better. It will probably look relatively unchanged. But what will look better, let's look at her smile. What's going to obviously look better is this crowding in the front is going to look much better. And then you can kind of see that her smile line goes up right here compared to this side. So that'll look a lot more leveled out as well when we get to that point. So I think she's going to look better by the time you're done leveling and aligning in every regard. And then you can tell her from there, when you go over to the aligners, you're going to be working on moving the teeth slowly back in the upper. So it's going to be, a little bit longer treatment. It should work well for her because of her strong muscles. The distalization plans work better for those patients. So some distalization in the upper with class 2 elastics to help advance the lowers a little bit. And you're going to balance however much class 2 correction needs to be done. Once you get her into aligners, you're going to balance between upper distalization and lower advancement. So you're getting a little bit of both. And that's why you want to wear the class 2 elastics. And then once the patients get tired of it and you don't want to try to correct it anymore with distalization, then I would resort to upper IPR to retract the uppers a little bit further to get rid of the overjet, and that's how I'd finish up the case. Okay.
Okay, thank you so much.
I hope you guys learned something new about the software. Did you guys see anything new about the software today that was helpful?
Yes,
Yeah.
I did.
Anything that you want to point out, Don, that maybe I missed on the software?
Not on the software. The case that you're working on here is actually very difficult.
It
These
is.
types of cases are very, very tough to work on. So you chose a very difficult case. And to fix that class 2, it may be unrealistic. So I don't know what the width was on that, but you might want to retrocline the upper incisor a little bit, and you're going to procline the lower incisor to reduce the overjet and accept some posterior class 2.
I agree with that. So, when you go and when you finally do get to the aligner setup, I'd probably give it a shot on my first set of aligners to try to fix the class 2. But then once you go through your first set of aligners, you're going to accept whatever you got. You're not going to get a full class 2 correction. And that's why I would then work on, some occlusal equilibration to get a stable posterior occlusion and fix the rest of your overjet problem with some upper IPR. Because I agree, I don't think you're going to, if this is the patient's actual bite, I don't think you're going to probably correct quite that much class 2, but you're not going to extract this patient. So let's see if you did the Ceph tracing. Yeah, you haven't done a Ceph tracing yet. And I didn't upload I did not upload the Ceph.
Sure.
So we weren't able to see the widths, but looking at it does look like you've got a skeletal class 2. So agreeing with Don, that your final is going to be a retroclined upper incisor and a proclined lower incisor because you do have skeletal and dental class 2 on a very low angle patient, which you're not going to extract teeth to fix the class 2. So probably a full correction is unrealistic, but I think you can do a great job for this patient.
So in your control is straightening the teeth and then correcting the class 2. Well, that's the patient doing that. And I'm sitting there questioning, even if he went distalization and class 2 elastics and everything else, I'm just questioning that, I think you're going to have to accept little class 2 and overjet.
You're going to improve it, but you're not going to correct it all the way.
Right.
Nice
Exactly.
thing is that you can do IPR at the end. Let's go back and look at your model digitally really quick. You can always do upper IPR. Look at how big this bicuspid is. So if you do IPR between these posterior teeth, that allows you to get the canine closer to class 1 without getting the molar any closer to class 1. And then you get your canine as close as you can to class 1 by doing some posterior IPR. And then you look at the overjet that's left, and this patient's teeth are a little bit tapered, so probably you're not going to have a lot of opportunity for upper anterior IPR. But once you get your canines retracted back as much as you can with posterior IPR, like right on the distal of that canine, you might be able to take off, but in that contact, you might be able to take off 0.6 millimeters of tooth structure and then more between these bicuspids. So you could probably focus more on posterior IPR to get the canines back without actually getting the molars back any further. But with those tapered incisors, I'm not sure that you're going to have a lot of opportunity for anterior IPR. So I agree. I think you're going to probably not finish this case, with a full class 1 and ideal overjet, but you still don't want to extract. And I think this is the best solution that you're going to get for this patient. So, but yeah, that's why I want you to start in brackets, because this is definitely not an easy case. And aligners would be very frustrating if you tried to do this whole case with aligners, in my opinion, because they're not very clinically large crowns and you got these strong bones. You can see those bones. Yeah, thanks for the insight, Don. Appreciate that. Any other thoughts or comments before we call it a night? All right.
Thank you, Gomes.
Thank you, guys. I sure appreciate you joining, and I'm grateful for the interest and the discussion, and I'm hoping that it helps. So, you guys have a Merry Christmas,
You
and
too.
we'll see you, I guess, the next time it's on the schedule. Okay.
Thank you.
Thank
Thank you.
you. Merry
Thanks, guys.
Christmas.
Thanks.
Merry
Same to you.